morning, everyone. Thank you so much for the introduction. My name is Jeff Wong. I'm a current clinical fellow in reproductive infectious diseases at the University of British Columbia. Thank you so much for the organizers for organizing this conference. I think it's really refreshing to see women's health being taking a forefront in HIV care at a conference. So I'm here to present you the data from our project, which looks at risk factors in pregnant women and individuals living with HIV. This is using a population-based cohort in British Columbia. That's been going on for 30 years, and we took 25 years of that data. Before I start, I do want to acknowledge, not even my conflict of interest, but acknowledge that I am currently presenting on the lands of the Piscataway and the Nacotchtank peoples, who are the first residents of the District of Columbia. I work, live, and play on the traditional ancestral and unceded territories of the Coast Salish peoples, which is now colonially known as Vancouver, British Columbia. My conflicts of interest are here. I'm funded by public organization, and there are no relevant conflicts for this talk. I know not everyone works in the perinatal space, so I just wanted to kind of give a little bit of a baseline to know what we expect in terms of the rates of preterm birth, both in Canada but also in the United States where we are. So in Canada, the preterm birth rate has been hovering around 8% and has been quite consistent throughout the last 10 years. And in the United States, this is a little bit higher, where the preterm birth rate is about 10%, which is very similar to the global average. As an obstetrician and gynecologist by training, I care about preterm birth. And the main reason why is because it is the leading cause of death in kids under the age of 5 across the world. It also has severe implications in terms of blindness, deafness, cerebral palsy, developmental delay, and many other adverse conditions as well. This is, and we know that for individuals who are living with HIV, they are at higher risk of having a preterm birth, even when they are on antiretroviral therapy. This is a meta-analysis that was completed by the colleagues at the University of Toronto, some of whom are actually in this room currently. And Rich really highlighted that for individuals on antiretroviral therapy, in the 12,000 pregnancies that they looked at, individuals were at higher risk of preterm birth. And even looking from a subgroup analysis at high-income countries, this difference persisted, and even the odds ratios are even higher if you look at the chart presented. So we wanted to take a look at this in our context. So just to set the context, many of you may not be familiar with British Columbia. So we are a province in Canada located in the Pacific Northwest. From a landmass perspective, we're 30% larger than the state of Texas, which means we have a large urban population, but also a large rural and remote population. Similar to other states in the Pacific Northwest, we are currently struggling with a concurrent substance use epidemic as well. So we wanted to see in British Columbia, what are our rates of preterm birth in women and individuals living with HIV, as well as understanding what are those factors that put individuals at increased risk for this. So in order to complete this, we used our population-based cohort, which is named the British Columbia Perinatal Database. This database has been around since 1994, and we elected to start our analysis from 1997 onwards, which reflects a contemporary HIV care regimen for individuals living with HIV in pregnancy, which is when highly active antiretroviral therapy or combination antiretroviral therapy first was implemented into the guidelines at the antenatal period. Our research team throughout the last 30 years have collected data from antenatal records, consultant physician notes, hospital records, and ultimately we completed our analysis using multivariate and univariate analyses as well. So in terms of the included cohort in our studies, for the last 30 years, we had 889 pregnancies, and after excluding 4 pregnancies prior to 1997, spontaneous abortion and therapeutic abortions, twin pregnancies, unknown gestational age at delivery, and maternal deaths, we were left with 578 pregnancies included in this analysis. What's surprising was that 111 of these individuals had a preterm birth, which puts our preterm birth rate at 19.2%, which is a lot higher than the 8% that we expected at baseline. I'd also like to highlight that approximately a third of these preterm births occur prior to 34 weeks. And that's important to note because that is the time period when individuals are at increased, when babies are at increased risk of death and other sequelae that I mentioned earlier. This is a busy chart, but just to give you a little intro into how to read it. So in terms of the column with preterm birth, the bracketed percentages is the rate of preterm birth if someone it has the cofactor that is on the left-hand side. In terms of statistically significant demographic findings, what we noted was that for individuals who were identified as Black, individuals had an 8% preterm birth rate, which is similar to our national and provincial average of preterm birth. However, for individuals who are identified as white or other, meaning not fitting within the other racial backgrounds that I mentioned that are above, they had a 19% preterm birth rate, which is similar to our study average. And our population who were identified as Indigenous, they had the highest preterm birth rate at 28%, and this was statistically significant. As an obstetrician, the typical risk factor for preterm birth is previous preterm birth, and we were not able to find a difference in terms of that, but we do see a trend going in that direction as well. What we noticed in our cohort was that for individuals who were able to access HIV care, this seemed to be linked with a lower rate of preterm birth. So for individuals who were on antiretroviral therapy at the time of delivery, they had a 17% preterm birth rate compared to 43% for individuals who were not on antiretroviral therapy at the time of delivery. For individuals with a suppressed viral load, they had a preterm birth rate of 14% versus 34% if they were unsuppressed at the time of delivery. And for individuals with a higher CD4 count, which we define as greater than 350, 15% preterm birth rate compared to 30% for individuals with a lower CD4 count. And this was all statistically significant as well. I know there's a lot of conversations about antiretroviral regimens and how it impacts preterm birth. About 2/3 of our individuals were on a protease inhibitor-based regimen. And when we analyzed the data in terms of whether the choice of antiretroviral regimen changes the preterm birth rate, we were unable to find a difference. I cannot address preterm birth without talking about concurrent infections as well. So what we noted in our cohort was that for individuals with a concurrent hepatitis C, chlamydia infection in pregnancy, trichomonas in pregnancy, bacterial vaginosis in pregnancy, these were all linked to higher rates of preterm birth. We did have a composite variable for genital tract infections, which included chlamydia, gonorrhea, trichomonas, and bacterial vaginosis, STI-BV, on the right-hand side of the slide, which noted that if someone endorsed one or more of these conditions, they had a 37% preterm birth rate compared to 17% if they did not have any of these genital tract infections. I'd also like to address substance use in our population as well. So what we noted was that for individuals who endorsed to any substances that's listed on this slide, they had a preterm birth rate of 31% compared to 16% for individuals who did not endorse to their providers that there was substance use in pregnancy. We were able to find a statistically significant difference in terms of individuals who endorse the use of tobacco in pregnancy, methadone in pregnancy, non-prescription opioids, and cocaine in pregnancy, as well as crystal methamphetamines in pregnancy as well. We didn't recognize that these cofactors do not exist in silos, so we made sure that we completed a multivariate analysis as well. We accounted and adjusted for history of preterm birth, PI-containing antiretroviral regimens, CD4 count at the time of delivery, and ultimately we were left with 4 independent risk factors, which included hepatitis C in pregnancy, substance use in pregnancy, genital tract infections, and bacterial vaginosis diagnosed antenatally, as well as unsuppressed viral load at the time of delivery. So in terms of the take-home messages from our cohort, What we wanted to highlight is that despite the advances in HIV care and the successes that we've had in terms of reducing vertical transmission, and these are successes that we really should be celebrating, we still recognize that we have a gap. Our preterm birth rate in our province remains high at 19.2%, much higher than the national and provincial average we expect. For individuals who have access to HIV care in the form of antiretroviral therapy and able to suppress their viral load, this seems to be related to having a lower rate of preterm birth in our cohort. For individuals with co-infection with STBVIs, these are common, and these also seem to be increasing the risk of preterm birth in people living with HIV. And lastly, the current epidemic of substance use and HIV overlapping is really causing a syndemic effect affecting our most marginalized population. So at this point, I'd just like to thank the conference organizers once again for inviting me and really highlighting and giving space for perinatal care in the field of HIV. I'd like to thank my colleagues who are part of the study, and I recognize I stand on the shoulders of giants who basically created this database prior to me being part of this project, and I'm only able to do this project based on the legacy that they have left. And thank you to our patients and clinic community advisors who provided their expertise also in informing this database and also how our clinic runs in British Columbia. Thank you.